Good afternoon and welcome to today's webinar, the fifth in our series of webinars on the My Health Record being presented by the Consumers Health Forum of Australia. Today's focus is digital inclusion and health literacy, and we welcome your online comments and questions during this next hour. We have once again a great panel of knowledgeable people offering a range of perspectives with us today. On my far right is Karen Gallagher. She's the General Manager of Implementation of the My Health Record at the Australian Digital Health Agency. Next is Dr. Chris Moy. He's a GP from Adelaide and chairs the Australian Medical Association's Ethics and Medicolegal Committee. On my left, Louisa Walsh, who's a consumer advocate and researcher at La Trobe University's Centre for Health Communications and Participation, and Mohammad Al-Kafaji, a director of the Federation of Ethnic Community Councils of Australia. Welcome all, and I'm Mark Metherell. I'm Communications Director at the Consumers Health Forum. The Consumers Health Forum has designed and directed this series of webinars with the funding assistance from the Australian Digital Health Agency, which of course administers the My Health Record, or MHR as we might refer to it. So to today's topics. Digital inclusion and health literacy, it seems to me, are linked in the sense that both go to people's capacity to interact and benefit from the health system, but they have effects in different ways. So I propose, for the start at least, to look at each of these aspects separately. If we go to digital inclusion, that is the ability, obviously, for people to work with, to be involved in and benefit from the digital technology. And according to one estimate, though, there's 2.5 million Australians who are still not online and are not getting the benefits of education, health, social and financial that you get from being connected. Digital inclusion is not just about computers, the internet or even technology. It's about using the technology as a channel to improve skills and in this case to enhance quality of life, obviously through healthcare. So you could say that digital inclusion is really about social inclusion, and I'd like to start with raising this issue with all of them, all of our panellists here, that given the current practice and culture in healthcare, do we think the typical patient, and particularly those with little digital skill, would get much support from health professionals, doctors, nurses, etc., to encourage them to use MHR to best advantages? And perhaps I should start with Chris Moy. He's the practicing doctor here. Chris, what's your view?
Look, what I'd say to you is that my health record is not the panacea for everything, and it's not going to solve digital inclusion problem, because that's a much wider problem. But what it does is really provide the information at the point of care, not only for health providers to improve the care of an individual, but the other thing it does is it allows for the first time access for that information to the individual. But if that individual can't actually access this information, it could be for a nominated representative or an authorised representative or all. Because in many ways, what it's doing is providing the information which has so far not been transparent to individuals about what their doctors and their other health providers have been thinking about them. So let me give you an example. We know that, for example, 40 to 80% of all patients, when they walk out of a room, even if they've listened in, will actually forget what they've been told as they walk out of the consultation. This is obviously going to be a bigger problem, for example, if an individual has poor language skills or does not speak English, for example. So they're going to go home with very little residual information about what's going on. In that situation, if they're able to access My Health Record for the first time, they're actually going to be able to look on their My Health Record and actually find out a little bit about what they've got. But in addition, say if it's a situation where they go home and they have somebody, again, if they're non-English speaking, and they have somebody who actually is their nominated provider who can actually look in there, they may actually be able to interpret some of this information for them for the first time. And in some ways it reflects what happens normally when a patient comes into my room. They're often going to come in with somebody who's a supporter, who's a carer, who will actually be doing that job. This time they're going to be able to do it at another time and place. So really, I think the main message I'd say to you is it is not the answer to digital inclusion, but having said that, I think there's a future that could enhance what we do with the information. But I think the main thing is that for the first time, this information is not only going to be available to other doctors and other health providers to improve the care of an individual. For the first time, it's going to be available and transparent to the individual or to the carers and representatives of that individual.
Thanks, Chris. What's the perspective of the ADHA on this, Karen? Where do we go in terms of reaching out to people who may not be technically knowledgeable in digital inclusion, etc.?
Thanks, Mark. I think what Chris has really pointed out is that, you know, that there is a community, and then we are talking about inclusion within the community. So I think it is important for us to look at the role of My Health Record within that community, and that the key benefit of a digital system in this particular aspect is for the healthcare provider, for that person, whatever digital barriers they may face themselves, to benefit them. So the fact that their information is able to be shared between their providers gives them benefit, even if they don't access their My Health Record for themselves. So I guess that really is my view of that. But one of the important things that we are doing is we are working with a number of advocacy groups and stakeholders, and we're also doing community engagement because this is really the space we get a lot of questions about, you know, how are people going to get access? What does this mean for people that don't speak English? What if someone has low vision? You know, what if they open up a shared health summary and don't understand what it means? So we get a lot of these questions, and I think that what the last few months has really done is raise an awareness around what it means to have access to medical information and what it even means for healthcare providers to share that information. And so we've opened a discussion, and this is part of that discussion, to take those questions and start to be able to provide those answers and then build the strategies and the tools to provide that support. So that's one of the things that we are doing. We're ongoing. We're doing a lot of research in the health literacy space. We've built over 40 organisation partnerships, and one of those being the Federation of Ethnic Community Councils, who's been really supportive in helping us get out to ethnic communities and speak to them in language, which has been excellent. We're creating a lot of self-help tools. And we're also continually doing product improvements. So we do a couple of technical releases each year, but that's all driven by the sorts of questions and concerns that we get, because we need to continue to look at how do we ensure access and equity in the use of My Health Record for the benefit of health outcomes. And I think that's the real key here as well, is to continue to look at the value of this digital tool for health outcomes. And probably one other point that I would like to make, just when I looked at that word literacy, is that the information availability is really key to literacy, and this is the first time that that's happening. So, you know, to be able to actually read some information about yourself rather than to be looking around Google and doing research around Google rather than looking at it yourself, I think that makes it's a big change and a big shift in people being able to be more involved in their care, or for their carers or their family to be involved in their care, because they've got information about themselves. So I hope that. Okay,
thanks, Karen. Louisa, what's the perspective, do you think, from the consumers? I mean, is this sounding like the way to go?
Well, I think that there's a lot of benefit to the ability of health professionals to share information between each other more readily. And I think that continuity of care, that communication between health professionals is a massive issue in terms of patient care. But I also think we need to think about what the role of My Health Record is meant to be now and into the future, and how that could evolve and change. And I think, you know, there is capacity for consumers to input their own information. Some of that health professionals can see, some of it they can't. So the consumer can then sort of decide which of the uploaded pieces of health information from the health professional side they sort of, if they want to hide things or if they want to leave them, you know, open to the health professionals, or which health professionals can see which pieces of information. So there's a bit of capacity to sort of, I guess, tailor the information, who sees what, and have control in that way. But is this a true sort of tool that consumers can use as a personally controlled electronic health record, where they can use this to build an equitable relationship with their health professional? Or is this more a device that and a way for health professionals to communicate more effectively with each other, to have that continuity of care in the background? And I think that's, you know, that's a bit of a juggle. Like, is this a true kind of patient portal, or is this a way for health professionals to communicate more effectively with each other? And I think, you know, from my point of view, the fact that a lot of the kind of, I guess, meatier information that patients could input about themselves, things like, you know, it's all the personal health, sorry, I get all the good terms confused, even though I've been reading a lot about it over the last 3 weeks, or the health information, the health note, the personal health note. So the fact that health professionals can't see that unless it's actively shown, so a consumer can't choose to allow to share that with their GP, for example, really takes away some of those opportunities potentially, I think, for making this more about an equitable relationship, a collaborative relationship with the GP. So, but, you know, it is early days for the record. I think, you know, it's been around since 2012, but in this sort of iteration, in the opt-out period of getting a lot of people onto it, and it doesn't mean that these things can't happen in the future, but maybe that's where people are getting a little bit lost about whether there is what level of control consumers can have and what level of input they can have, and how they can use this to enhance the communication with their health professionals, or whether it is that kind of that information sharing for continuity of patient care, and where the benefit sits at the moment.
Oh, thanks, Louisa. Mohammad, digital inclusion, is this a more difficult challenge for people from non-English speaking backgrounds, do you think? It's laying a sort of another technical step for them to go through. What do you think the experience has been so far in terms of accessing My Health Record?
Sure, that's a really good question, thank you. Look, I think it's essentially, the question is about access and equity for people of culturally and linguistically diverse backgrounds. You know, when I think about my family and my parents, I didn't think that my mum would pick up a phone or know how to use a smartphone, but, you know, it's quite surprising that she is actually one of the, you know, heaviest users of technology. So I think I would say CALD communities are quite resilient when it comes to, you know, adopting to change and adopting to using technology to, you know, manage the, for example, health records or Centrelink issues or whatever. They know how to work, I guess, with the system if they are shown how to use it properly. A good example of that is, I think there was a good case that, you know, beautiful design is important in terms of user experience, because people get to, used to knowing exactly what buttons to press to do what they need to do. So you better not change that layout, because if you do, things, you know, they could put themselves in trouble, because we need to acknowledge that not everyone speaks English, or we can't also assume that everybody speaks their own language, can read or write in their own language as well. So I think people will adapt in those ways. So I guess in terms of you know, literacy in, you know, technology literacy, I think people are quite resilient, but I think it's all about access and inclusion and equity for those people who can't read or write, or, you know, for a lot of them do need translators and interpreters.
Karen, can I ask, what has been the experience as far as MHR is concerned so far in terms of people coming from diverse cultural backgrounds?
I'm actually unsure of the makeup. Do you mean of how many users are on My Health Record? Because that's not something that comes through as part of the system data. And also the system currently at the moment is English, so it's an English navigation. So the website, we have translations on that, and it's also got an easy speaker, an easy read speaker. But the actual system is in English. So unfortunately, I can't give you the data on that one, Mark.
Yeah, yeah. So in the future, aren't there going to be a lot of people who don't read or speak English? What's going to happen about their access to MHR?
Yeah, so we're actually working with the Federation of Ethnic Community Councils and have recently actually been speaking with them about that, about the fact that currently if someone went into a My Health record, would they be able to use the tool because it's in an English format. And we do, as I mentioned, we have a product improvement group and we take a lot of feedback from stakeholders, both from clinical consumers and different advocacy groups, and we look at those in terms of what barriers are there to use, what are the things that are maybe stopping people from using something effectively, and then we look at the potential gain and benefit to the overall objective of My Health Record, which is to improve health outcomes, and then we put those improvements into technical releases. So that is something that we've already received feedback on, and we'll go through the evaluation process as to what changes in the future might be made to as Mohammad said, to increase the equity of the ability to use My Health Record.
Right.
Yeah.
Chris, can I ask you, have people looked at, or the medical profession looked at any risks from digital exclusion, if I can call it that, where because everybody's gone towards the MHR model, there may be those who aren't digitally equipped who are going to be left behind? Is this an issue, do you think?
I think quite the opposite in some ways, because I think Karen has actually indicated previously that, in fact, even the individuals from a health point of view who, are not going to access and have stayed in the system, as long as they know that they've got the right to opt out if privacy is more important for them, if they stay in the system, the health benefits will still be there because it will link, when they go to see another doctor or another health provider, for the first time the information is going to be there at the point of care. And we're going to avoid those, hopefully a lot of those 200,000 a year hospital admissions from medication mismanagement because of lack of information at the point of care. So the benefit is already there irrespective. Could I just take one little point from Karen, because Karen's made a really good point, because I think the thing that I say, and I've been involved in this a while, is that I think people misinterpret what the My Health Record is. They look at it what it is like now. And what we're trying to get along, what we're trying to get over the line is basically a digital Dropbox folder, and I'll put it here, it sits up in the sky, right? And all it does is contain copies of the very same documents that a doctor might have, like a summary and some results and those sort of things. But the difference is now it's accessible at another time and place for other health providers where they never might have seen this before to benefit the patient. But also it's accessible to the patient, or in a situation where a person is not actually health literate or may be culturally and linguistically diverse. In those sort of situations, the nominated provider, for example, or authorised provider that's appointed can actually access it for them. And the difference is now, what will happen is if they turn up into a emergency department or whatever, their family member, for example, who's got access, could actually punch it up, and I can show you on the app, you can just show it, and they can actually, instead of turning up cold when they have no information, the hospital will have no information, you can show them the history. I think the other important thing that's really important is the reason why I got involved in this was actually not about the medical history. It was actually about the fact that when patients are actually in situations of medical care and there's no information, they're in an incredibly vulnerable situation. The power differential is great. If you don't know your history, but also if, for example, very often you're going to end up in hospital when you've got lost decision-making capacity. You're actually unconscious or you're actually delirious or something like that. The advanced care directives and advanced care plans that patients can upload, but also the ability to actually put their emergency contact numbers are incredibly important, particularly more beneficial, say an individual has, well, I would say dementia. And unfortunately, when a patient ends up from a hospital, from a nursing home, for example, with dementia, quite often there's no information about medical history, there's no information about the advanced care directive, what their wishes are, there's no information about contact details, but also, and I think Louisa put up a really good point, I think that the record needs to be more than just about medical history. It's got to be about what that person is.
Louisa mentioned the personal note, which is not
exactly.
allowed.
So I think the thing is, well, I'm going to get back to Karen's point. I think Karen's point is exactly right. We're at the beginning of this. This is a folder And I think that consumers need to start taking control of this and actually start making this, instead of half empty, make it half full, because they can build it the way they want. Because that person who comes with dementia into an emergency department, I'm going to frankly say to you that quite often their care is suboptimal and they are not treated with the sort of respect that they should, because people view that person as a diagnosis with dementia.
Right.
And instead, that person was somebody who had, who's a very important person, did a good job, is a great husband, a great father. That sort of information about that person can actually be added to the My Health record over time. And I think that's the way we have a chance to evolve this thing, and I think consumers need to be part of the journey. So instead of a person coming into a hospital or emergency department or seeing their doctor when they're vulnerable, just being a diagnosis of a problem, they can be a person now when they can't actually convey that information.
Right. Mohammad, is that point coming through to your communities, that in fact for people who don't speak English, this may be a plus in that this patient record is available, say if they end up in hospital or at some other place?
Absolutely. Look, I think My Health record is, I think it's revolutionary, right? But especially for older Australians with linguistic and culturally linguistically diverse backgrounds, because of exactly that case. What happens if you do land in an emergency situation and, you don't have your children or siblings or whoever to translate for you, and having those records right there for you, right at the start, in that critical time when they need to know quite a lot of information about you, that could save lives. But also, My Health record could say, well, does this person need an interpreter? What kind of language, what dialect? Because it's quite diverse. It's not just Arabic or Farsi. There's, different, different dialects within that, because and with those dialects, there are different cultural baggage that comes with it, if that makes sense. I mean, people come here as refugees, and they might be, for example, North Sudan, South Sudan. Sometimes they don't want to be translating for someone who, or they don't want someone translating for them who was from the other side of the fence. So there's quite lots that My Health record could have that information in there to select the appropriate translator or interpreter at the right time when they need it. But just in terms of, I guess, knowing about My Health record and actually the usability of it, I don't think, our communities actually know about it.
Really?
It's, I mean, I've lived here for 15 years, and, up until a few months ago, I've never heard of My Health record before, and it's been going for a while. And I could be wrong, but I think a lot of Australians don't actually know about My Health record and the benefits that it could bring to them. I think if that message is conveyed, and if people know that, wow, I can actually be in control of my information, and who to give access to, and all sorts of information, I think they would actually sign up to it. So for consumers, we managed to get them to opt out rather than opt in. So we've got a pretty critical mass there. For this to work, and I think this is part of expectation management, is to make sure that the practitioners also take it up in a large scale, to make sure that it is worthwhile their time to actually go in there and update their records and actually manage that. Because if it doesn't, people will use it once, and if it's not up to their standard, or if it doesn't meet their expectation, they won't go back in there and use it again.
Yeah. What do you think, Louisa? You've sort of looked into this.
Yeah, so I'll talk about my personal experience first and just pick up on a few points that have been made around the table. So number one, with this increasing desire for consumers to be able to input more information, then obviously there's increasing need for digital literacy and health literacy to be able to do that. So this is why the point I was making before about what is this record for. As it becomes more interactive, as it becomes more person-controlled and person-centred, then there's this increased need to address the barriers of digital and health literacy. But secondly, my own experience really comes, we talk about digital literacy from the consumer point of view, but also we need to acknowledge from a health professional point of view, and maybe not GPs who already have the systems in place that mean ease of access into the record, and ease of transferring information from one electronic record to another. But So for my own experience, I'm a transplant recipient and most of my care happens in a specialist environment. And then the GP I see for very, simple things. So, vaccinations, stitches out, that sort of stuff. My GP has no interest, has never spoken to me about my health record, even though I have one. My specialist, I know that the hospital that I go to has finally got on board, but there's never been anything inputted from there. So actually, my health record has the stuff that I've put in terms of my medications. It has my Medicare data and my PBS data, and from that, you could make an inference that I've had a transplant if you understood the medications that I was on. But there's nothing that actually says any of my diagnoses. So for me, in an emergency situation, if someone opens up my health record, hopefully the fact that there's no health summary in there makes them go, aha, this isn't a complete record. Yeah. But actually the incompleteness of the record makes my care potentially more dangerous in a situation where I can't advocate for myself. And so I think that's a really important point that you've made, Mohammad, about, yes, we can get consumers on and we can put them into an opt-out situation, but if we don't have those concurrent systems at the provider end, then you end up with a situation where potentially an incomplete record that people think is complete is more dangerous than having no record at all and going off information, like having to start from scratch with that information. So that's the point. And then, yes, so I work for the Centre for Health Communication and Participation at La Trobe, as you said. And part of my work there has been to look into the health literacy demands of my health record. And I started that back in 2016-17. So I'll just have a drink. So we actually did a lot of analysis back when the health record changed from the personally controlled electronic health record to the much more kind of snappier My Health Record. And that analysis looked into a couple of things. So the first thing was that we did a big content analysis of all the consumer-facing information that was available online for My Health Record, both from it wasn't the ADHA then, but what was prior to the ADHA, and also from other agencies around. So we had a look and we did things like readability, looking at currency, looking at the author, looking at how things linked to each other online, just to get a good sort of understanding of, from a health literacy perspective and from some of those things that people use to judge information quality, sort of how, just a map of how things were at that time. And we also looked into usability, using some previously developed by other researchers, usability checklists that had a real focus on health information and health literacy. And through those two pieces of work, we sort of found at that time that My Health Record and the information surrounding it, almost globally, not just from the government information perspective, didn't really meet the information needs or the usability needs of someone with low digital health literacy or low digital literacy or low health literacy. So that was obviously back in 2016, and there's been a lot that's happened since then. So we've sort of repeated that study at the moment, and the analysis isn't complete, but we're seeing some improvements from the consumer information side of the My Health Record website in terms of usability, but probably content-wise, and obviously there's also been an explosion in content around opt-out, so an explosion in information, but probably information content-wise and also the usability of the record itself probably still is lacking when it comes to meeting the needs of people with low health literacy and low digital literacy. So again, I come back to the point of, if this record, especially moving into the future, is going to become more person-controlled, more consumer-controlled, with the ability to input more information to control what is seen and what is not seen, to try and use this as a more collaborative tool between health professionals and consumers, then those things really need to be addressed. Because actually to use the record at the moment, and even to understand the information that's provided to then get on and use the record, is very reliant on consumers having very high levels of health literacy and digital literacy. So that's just something that really needs to be considered when we think about how the record is going to be and what it is going to do moving forward. And I think all of these things that you've mentioned, Mohammad, are great potentials, and I think that's sort of what consumers want it to be able to do. But at the moment, those barriers are probably going to be very significant for a lot of users.
Karen, can we expect to see the continued developments meet some of the issues that Louisa raises?
Yes. So we are working with, as I said, so I guess one of the things that I think is really important throughout this program, because I come from a communication background, is to not assume that you know best and to listen to the audience. And I think that that's one of the really, I think, quite amazing things about what is happening, has happened since the agency's been started, is how many people we're working with and listening to and getting feedback from consumers. So that is informing what we're doing moving forward. And for example, we have worked with the Council of Intellectual Disability to recently develop easy read materials. We've received feedback on our Indigenous materials, and as a result we've then developed those into audio versions in 13 different Indigenous languages, and we've modified our messaging so that it made sense, not just in the language but in the meaning of the language. So we're going to, I believe from a communications perspective, almost extraordinary lengths to try to ensure that we're able to meet the needs of the user. And from the website perspective, I'm glad that there's been an increase in the usability of that, because as you know, the website was relaunched this year and we've gone through a process of re-evaluating our communication, and the team continue to do that. So one of the things that continues to inform that has come off the back of this hugely increased interest in digital health. We've now had over 1 million people visit our website. We have people email us all the time if they have a problem. They call our helpline. So we're starting to really understand where people are finding problems. And what that's allowing us to do is to then get those problems and start to say, right, where do we solve these problems? Because, so for instance, we've developed a number of how-to videos. And those videos might sit on our website, they might also be on YouTube, but then we've also provided them on a microsite that's accessible by, I think it's probably about 500 different organisations now can get that link to that website, and if they wanted to, they can download that video and show it to someone. So we're trying to make sure that those materials are available, but I think we definitely have work to do in terms of continuing to make sure people understand that those tools are available and having them available in the right place. And we definitely need to continue to do that, because right now we have 6 million registered accounts, and at the end of the year we're going to have way more than that. So we really are going to move from a focus on awareness and providing enough information for people to make an informed choice, should I be in or out? And then we're going to start to move to enablement. How do we help people use this tool? And to your point, Louisa, why would people want to use this tool? What's the role for that? And I read, you know, when I was looking at the webinar and what we were going to be speaking about today, it said, you know, a tool for everyday life. And I thought, I'm not sure for me that's the role of this. I think it's going to be important for me and my family and my children when I have a health interaction. And that's what I think is important for me, is to understand what the utilisation is for me, and that as an agency we consider our role with My Health Record in a broader digital context. You know, we're not Apple, we're not going to be counting steps anytime soon, I don't think, but I think it's important for us to understand that, to say what is this for me, and to that point as well about, can the doctor see my notes? For that personal health note, no. But does the information, because I can see it, allow me to ask better questions when I go in to have a conversation with a GP? I don't understand what this means, and you've put it on my child's record, and now you're sending me off to see a specialist, and they're going to talk to me about stuff I don't understand. So I think as a tool, there is ability to use it in its current state, but the best information we're going to get about the utility is when we have lots more people using it. And that's the point of, I guess, moving from opt-in to opt-out. So we're going to continue to learn and listen.
Okay, well, that's the digital inclusion aspect of our discussion today. Perhaps now we should move to health literacy. which has been defined as the cognitive and social skills which determine the capacity of individuals to access, understand and use information in ways which promote and maintain good health. Do each of you want to just give a quick idea of how you think health literacy will be affected with the rollout of MHR? Perhaps I should start with the consumer, Louisa.
It's an interesting question because at our research centre we very much take the view that health literacy is a skill that can be built over time. It's not a sort of a kind of reductive thing or a problem. It is something that develops and grows and changes as people kind of get more involved in their health and learn more. So the involvement, the ability to see information about yourself, like you say, is great. I think there's capacity or opportunity to go beyond that, because what does, like you said, what does someone do if they then find something about themselves that they don't understand? And where do they then go? And how do they then judge that the information that they're searching for and finding is good information? So again, where there's capacity in the system to help people understand how to judge good information, to direct people to websites that are trusted, that sort of thing. Because, you know, someone is right there on their computer looking at something about themselves, they are going to then do a search about themselves. And that's not a bad thing, but it's understanding and judging that information, you know, if that information is available and right there. Because, you know, very few people are going to then make an appointment to go and see their doctor to ask them, what does this word mean? Yeah. So, you know, I think, like you say, it's good that people can look and see information about themselves, and hopefully that will then prompt further investigation, which can help grow health literacy. But I think that there is possibly capacity within the system to help guide searches and information finding.
Yeah. Mohammad, do you think the My Health Record will help with health literacy, people learning more about healthcare, how best to keep good health, etc.?
Yeah, I think so. Absolutely. I mean, exactly what Louisa said there. I mean, you know, some of those fancy words might come up, and the first thing I'll do is put on Google and see what Dr. Google says. Yeah. And, you know, God forbid, you know, one of the causes down the track might be cancer, and I think we need to kind of we need to manage that. We need to make sure that, hey, just because you saw this, it doesn't mean you know, it will lead to X, Y, Z. And I think this might actually frustrate the GPs later on, because they'll make an appointment and say, hey, I Googled this and it says this, tell me about it. And all right, you know, I'll be patient with you and I'll explain this. And then they might turn around and say, but it said it might also lead to X, Y, Z. So, and you might have this beautiful discussion instead of actually, you know, just trust me, I am your GP, and I'm delivering I'm telling you what this is and what this is not. But, you know, it can only be a good thing, because people will actually be interested in their own health, and we'll find out more. But I think the GPs might find it frustrating.
Chris, on this trust me, I'm a doctor sort of angle.
I love that. I love somebody who said that.
One of our online...
Made my job easier.
One of our online questions is from Jane, who asks, the discussion's all about the use of the consumer portal as a tool and how it's not so easy to navigate. Third-party apps can provide a more user-friendly experience for people. What's happening in this space? Okay. What do you think about that? Apps?
I'm going to take the question back a bit. The whole issue about health literacy, I got asked this question. Oh, you know, we did a talk about My Health Record, and a consumer stood up and said, "Hey, it's not going to solve my health literacy." And I said, "No, it isn't actually." But I said to him, "At the moment, what information do you have about yourself?" Zero. And I said, really, at the end of the day, the issue on the quest to health literacy, it gives you the first step only, which it gives you some information that you've never had before, okay? Previously, this message is zinging around, I'm faxing it to people, and it's in my notes, but you've never seen it before. this doesn't fix your health literacy problem. But I think the thing that happens now in terms of being able to take it from here is to understand, and the reason why I gave this example is understand what Karen's been trying to say is that the My Health Record is a sandbox right now in terms of how we develop it. We're the beginning of something. Don't judge it on what it is now. Judge it on what it can be for the future. And really, I think as consumers, instead of actually looking at it as something, well, somebody else should build it, actually understand, become a part of building this properly, because this is something that could make, the way the third-party app side of things isn't, I think I said, I could show you my health record, but what would happen then is, I think the way it should go, and the way I envisage it, is that you have your My Health Record, you can open up your file, and you can actually see your diagnosis, which is a scary thing, because you have all these medical terms, but you might see type 2 diabetes, for example, and you go, what's the type 2 diabetes mean? Well, there is the potential with these third-party apps to actually be able to launch off that into a reputable information source, such as Diabetes Australia, which might actually be able to give you information about the differences between the diabetes. I mean, this is the sort of way I think we need to go, but understand that the way it is at the moment isn't the way it has to be. But I think all of us, doctors, consumers, need to take ownership of this and actually, I mean, I have this principle because I think it's a lot easier to criticise than to create. And I very much take the view that you actually, the Kennedy, don't ask what, you can, what we can do for you, but what you can do for this. And I think that in some ways, this is something you can finally own. And that's why I think it's very important. So I'm saying that as a doctor, and it may make my job a bit harder sometimes. It has actually, because people have come in and said, hey, Chris, you got it wrong. It was my left arm that I actually had my operation on. I go, oh, no. But in fact, it was good, because what it did is it made me correct the data, and I made the data better. And it was good for me, but also I think in terms of actually the consumers in the future, I think the way to understand it's the first step. It gives you information you've never had before. Build it from there. That's really up to the consumer group, not the doctors group, to do this.
Do you think, Karen, the people, we're in the middle now of the opt-out season, if you like to call it that, I mean, do you think people have the health literacy as a rule to make the best judgment on whether or not to stay with the My Health Record?
From my experience, the more interested you are in this and the more concern you have as to what it might mean for you, the more likely you are to go looking for more information and to ask more questions. So I think that's probably goes beyond health literacy, and that goes to people's reaction to the media. That concerned me. I don't know what that's about. And what we are finding is that people are asking a lot of questions. And I do think as well there are a lot of people out there, including the AMA and the RACGP, Consumer Health Forum, and a number of other advocacy groups that are advocating for people that they may be concerned that may not have the health literacy to make an informed choice. And they're doing everything they can to provide the information and to ask questions. And we have hundreds of questions asked so far that are being asked on behalf of people that may have lower health literacy. And as a country, our health literacy is, as you were saying, Louisa, it's pretty good, but there's a whole group of people that aren't. And I think you said as well, there's 2.5 million people that aren't, on digital. So I think there's a lot of learning that's occurred over the last couple of months. I think it will continue, and I believe that the opportunity here is for people to make an informed choice. There's definitely enough information out there now to allow them to either feel comfortable, that they're comfortable with the benefits, or to say, no, I still don't know enough, I don't trust this, and to opt out. And that's really what this period, as you call it, the opt-out season is about, is giving people enough time and enough information to be able to make a choice. And at the end of the day, if they don't want to be part of it, they can opt out. And then they can watch and see as well. I think that's the other thing as well. If they wanted to watch and see, they can opt back in later. And I'm sure there'll be some people that make that choice as well, because there will be an ongoing learning about this. And that's what I guess I'm probably the most pleased to have been part of this program for, because at the start of this year when I said to some friends, I'm going to work on my health record and I'm going to be unavailable pretty much to my family for the next 8 months, they were like, I don't really know what you're talking about. And now everyone knows. And I just think it's fantastic that there is this national conversation going on about digital health, and that we're sitting here talking about how we can improve health literacy. I think that's fantastic. But if people are concerned they don't have enough information, the key is to ask. We've got community engagement officers and events. There's over 1,300 events that have already been attended where there's someone to talk to. We have a helpline that's open 24/7 a day. We have a website. There's heaps of videos on YouTube on our My Health Record channel. And we have easy read materials and low literacy materials as well that people can access to find out more.
If I can just add to that, I think it's really important to get the information out there, but I think it's also really important to correct the record on some of the issues that have been raised in the past. One of them being, privacy and security of My Health Record, because obviously, for example, people saying that this potentially, this data could be accessed by other agencies, for example, immigration or health providers, and rumours, go around community very quickly, especially, for example, for cold communities, they use WhatsApp very effectively, and the information goes like wildfire.
Yes, indeed.
And surprisingly, my sister actually posted something, you should opt out to the family line, and said, this could potentially be, your information could be shared with other agencies, blah, blah, blah. Everybody should opt out. It was pleasant to see that they know about it now. But I think now we need to kind of go back and actually say, well, no, the security aspects of it have been addressed, and the privacy aspects of it, you have full control over now. And, it is protected by legislation. So I think some of those myths and misconceptions need to be addressed, because otherwise you won't have buy-in, or, a lot of people have already opted out without actually knowing the benefits for them, with, added that level of misunderstanding, I think.
Thanks. Louisa, do you have any idea of just how many, or what proportion of the population has a clear idea about risks as against benefits of My Health Record, do you think?
I have absolutely no idea.
Oh, that's a very...
I have absolutely no idea about the proportion of the population who knows about My Health Record. I have no idea about the proportion of the population who is able to, is judging those risks and benefits. I think possibly the opt-out trials could give you, that happened up in Queensland and in New South Wales, where we are. Maybe that data was collected by them, but that isn't data that I have seen about, people who had a record without knowing that they had a record. I don't know. And I think there's a couple of things that I want to pick up on. Number one, this idea that that consumers should be the ones who are responsible for growing and developing and embracing the record. But we're only one part of it. We're only one half, and the other half is really health professionals. And it's only very recently that my main, very large tertiary hospital in Melbourne actually got on board the record, and I have no idea about how to get my specialist to upload any of my health information onto the record, because they're extraordinarily busy. I think if I asked them, any of the specialists that I see, they would give me a blank stare, because I don't know how much it's filtered down from the executive. So this idea that consumers somehow have greater responsibility for what happens in the record, that we are, we opt out, but there's no opt-out equivalent for health professionals, that is actually, that's an issue. And it's an issue of power, because there's been, the whole time since the inception, there's kind of been this idea that consumers coming onto the record will be the driver to talk to their doctors, to get the doctors on board to using the record. And I think that doesn't take into full account the power differentials that naturally exist in that relationship. And also, how much... It's unavoidable that having this type of record increases the administrative burden for consumers as well. So, something that we previously couldn't access, yes, we now can, but there's also things that we have to consider about opting in, opting out, weighing up benefits, risks, whether we want to carve off some parts of our records so not all health professionals can see them. These are all sorts of things that we didn't have to think about before. That doesn't mean that it's a bad thing that we're thinking about them now, but it's just, I think there is a little bit of falsehood in this idea that consumers are the ones who are like railing against it, and that health professionals are the ones that don't seem to have that place as strongly in building it. So I think, I just wanted to pick up that point because I think that was a kind of a...
Yeah.
Can I just say that I think you were supposed to ask me a question about what the medical profession were doing about this. And look,
Yes.
well, I was going to come. Yeah, you were going to go straight for that one. Look, the bottom line is that doctors by nature are skeptics. We do not want to be people that actually take the first medicine and make you the guinea pig So it's important to have doctors skeptics. There have been a lot of concerns, and to be frank, a lot of the issues that have happened has been because there's been nothing to bite on for them so far to actually work with. It's a chicken and the egg situation. The thing I would say to you is to what you said, is the experience in Northern Territory and in the opt-out areas. See, the problem is we're looking at it from where there's nothing there to bite on at the moment, and people aren't actually... It's a theoretical exercise for us at the moment. But in the Northern Territory, for example, when they did take it, what actually happened is, yes, at the start it was very slow, but when they hit 50% connectivity between the providers, but also the users, it took off. Because at the moment, the problem is it's chicken and the egg. It's kind of like not enough people are connected, so I've got a 20% chance of, 25% chance of actually having a patient on there, and then not much data on there because nobody bothers because there's only 25% chance on there. And that's the whole point of opt-out, to tip it over into a critical mass situation where you actually have a majority of people on there and a situation where the majority are... Then what happens is that people are going to go, the first time they look in there and they go, oh God, does that patient have an allergy, or what medications are they? They're going to look at it once and they're going to go, I get it. Now I know where to get. Or I couldn't reach that pathology result because I don't know which lab they went to.
Can I ask, in Darwin, are all the specialists now on MHR?
I don't know whether it's Darwin, but I think it was actually in a certain area in Northern Territory, but it was actually a trial report, which you can actually read about. But I suppose that's it. It's a chicken and egg situation, which we haven't hit. And to some way, it's kind of like saying, well, OK, what user... And I've got to say Victoria's been one of the worst places so far in terms of penetration. But, for example, in Sydney, for example, there was one of my doctor friends just received, he had a patient who had, and I can say this because he gave permission, had a major neurological condition, turned up, no notes. He looked on my health record, had all the specialist letters and the results, and didn't have to put the patient through this. And the irony was, we can't get this from our local hospital in South Australia, but he had it, and it made such a difference to this person because he didn't put him through the nightmare of the full investigation again. So the point is it's kind of like chicken and the egg. You can't see the future because you haven't been through it yet, and it isn't reaching that critical mass. So I accept what you've said there, because I think in some ways it's kind of like there hasn't been this compulsion to do this, but the flip side is, and I actually don't say that it's the consumers are the ones who've actually railed against it. In fact, I actually think that the health providers have been, to some degree, in the same boat. But understand their role. They have actually had this... They had this role of being the skeptics and protectors, and they feel they should be skeptical about most things. But the experience in certain areas, such as opt-out areas, where people have found much more new models of care to look after homeless people who actually haven't had records because it's not continuous, or situations where you are dealing with, disconnected communities that move around. There have been, you can see by the trajectory that's where we need to get to.
Can I ask, is the My Health Record administration relying just on sort of rising critical mass? So if we take the hospital specialist involvement, is there anything ADHA doing to sort of drive that?
Yeah.
Or are you just relying on natural...
we're not.
No? So what's happening?
So I guess you could say behind the scenes, we have been working very, very fast, I guess you could say, very collaboratively with all of the state governments who are all part of the funding model for the My Health Record expansion program to bring on board public hospital systems. And so that has progressed rapidly this year. And I think Chris was saying that Victoria and South Australia will come on board a little bit later, but they've got strategies in both of those states, but all other states will have My Health Record in public hospitals. We also have been working, one of the biggest focuses for us to add value to the record for GPs and for other healthcare providers has been pharmacists. So we've been working with the Pharmacy Guild and also directly with pharmacists and community pharmacy to get them connected to the system, So we'll have the majority of pharmacists connected by the end of the year. Also pathology labs, that's another area where we see there's about 15% duplication in blood tests. And so by having pathology and blood tests be able to be uploaded to My Health Record means that people can see that they've had a blood test versus reordering it. So definitely that the agency and also the healthcare providers have been very aware that it's the content within the system that will ultimately be of value, and you don't have content unless you have these people connected. So there's been a very strong program of work to bring all of those connections on board. Also a program with the software vendors that run the clinical software systems, the conformance systems, to ensure that the use of My Health Record is simpler than what it has been in the past. So that's made a difference as well. That's the evidence that we're hearing, that stories coming back saying, oh, it's easier to use. So that's good because we've reduced the barrier of use there. Definitely there is the reality of the fact that some people before haven't been that impressed. So part of that is we've had a training program in place, both RSCGPs working with us on this, plus also all of the primary health networks around the country. And we've been out training healthcare providers now in all GPs and pharmacists this year, and also GP practices and pharmacists, and also the jurisdictions, the state governments are working with us to do training within the public hospital environment, because we're quite aware that one of the biggest benefit areas is going to be in the emergency department, and so it's important that emergency department staff know that that's somewhere to look for information, and that there's information there, and then also that the discharge summary from the hospital goes back to the GP via this system. So massive piece of work there in terms of providers, both in connections and then in education, and that will go through, continue. So in terms of specialists, I think that continues to be a focus for us, as does the allied health, so physiotherapists and psychologists. With specialists, I think that within the public hospital environment or the private hospital environment, that's a way for us to reach them and for that information to go up because they're connected. Obviously, some specialists don't use digital systems the same way, and so there's an additional step for us. But I think that as we move forward, that all of the healthcare providers, like the NT example, the Northern Territory example, are going to say that's the easier way to get this information, or this complements what I have already on my system, and it's faster. I can look here, see if it's there. And it saves time with, you don't have to call the pharmacy, you don't have to call back to the doctor. So that's a lot of the education as well, to kind of make sure that healthcare providers see the benefit in it.
Thanks, Karen. One of the big ongoing claims made in support of the electronic health record is that it should bring more knowledge and information towards the consumer because they have ready access to what their doctors prescribed, etc. Now, I was interested, I think, Chris said the power differential, doctor-patient power differential would be moderated, but you seem to have a different story. What do you think? Does this have the potential to, if you like, equal up the power imbalance at all?
I think, as Mohammad has talked about, if it's a prompt for people to learn more about their conditions, bring that learning back to their doctor, do their own research and come back and ask, between different treatment types or, screening decisions, that sort of thing, there are opportunities there. And I think those relationships grow and change as someone's health literacy grows and changes as well.
Yeah.
So, there's potential, and that I think that's a larger cultural shift in medicine and person-centred care and person-centred practice, and maybe this will be a part of that. But again, as it can't be the solution to digital inclusion, it also can't be the solution to person-centred care. It is just another tool, and the people who are most likely to benefit most from that relationship change are the people who are most likely to be able to use and tailor their health records, so the people with higher health literacy anyway, and the people with higher digital literacy anyway. So again, you know, it's about how do we support people to develop those skills who are maybe starting from a bit of a lower base and not starting with those skills already.
I'd actually to take another tack on this, and I'll actually take a different situation. Okay, so I take it much more to daily situation. I had a patient the other day, she came in and she complained about her treatment in hospital. They didn't believe her husband had allergies when he was unwell. And so she actually pulled out a MyHealth and said, there. And so funnily, you know, the doctor had been adamant about that stage, was going to give this patient something, and the power differential changed at that point.
Right.
I'll give you another example in terms, and I actually say to you, for somebody in a situation where individuals are culturally and linguistically diverse and they come into the room for the first time, and even if they have an interpreter there, the time taken to get a history and examination in a 15-minute appointment is going to be much higher. You know that.
Yes.
I'll get to at the end of the consultation, everybody's getting pretty frustrated, and the care of that individual drops off. You know, pretty quickly, and the frustration level goes up. And you do wonder, you probably understand from the group that you, about the sort of ways that maybe doctors sometimes appear to be frustrated when treating certain patients. Well, how about if I go in, I see the history, and I actually spend more time actually with the patient and dealing with the problem? You see what I mean? This is what I mean by power differential. I'm not talking about this sort of big issue. I'm talking about this daily grind issue where it's actually right in front of you every time, where your odds are stacked against you because the information isn't there, and the balance of communication is actually really against the individual in front of you.
Well, Chris, sorry, the consultation is almost over. We've run out of time, but the last word, Louisa.
I was just going to make the point that it's probably getting a bit into it in the last, you know, now we've gone at 3 minutes over, but yes, that's true that the information is there, but if we're coming to situations where a patient isn't being listened to and they need to pull out their MyHealth record as evidence, the information that's in the MyHealth record that they can show as evidence is still information that's curated from their doctor rather than being a full record of their health. And so, you know, I come back to the issue that if something goes wrong with my health and I need to make a complaint, I still need to get an FOI to actually access my full record, because this isn't a full record. So, again, it's a tool that can be utilised and can probably be utilised best by people who have, you know, high levels of digital literacy, high levels of health literacy, and, you know, already have some strength in their relationship with their doctors. But it isn't a full health record either to consult in, you know, in when there's complaints or if there's actual issues with health. So I think it's one of the many tools, but it's not the solution to person-centred care, as it's not the solution to health literacy, as it's not the solution to digital inclusion.
And I think that's a really good point to end on, which is MyHealth record has its role within care provision, and it will improve the access to information, both for doctors and for consumers. And that's a really good start point for us to have when we're looking at digital health. And that's a system we don't have currently. So, you know, if everyone can work together from here to say, you know, this is my interest in this and this is what I'd like to see, then I think that's a pretty good outcome. And, you know, again, it's still everyone's choice to be part of it.
Mohammad, do you want a last word?
I don't know about the last word, but I just wanted to kind of mention that, obviously, just back to your point, I think for the new doctors, I think there needs to be a lot more training as part of the studies or continuous development. But just wanted to kind of pick up on just the issue of new migrants coming to the country, because they will automatically have a MyHealth record. And I think, no, that's not correct?
No. So newborns and new migrants get an opportunity when they apply for their Medicare card to choose whether or not they want to be part of the system.
Great. Thanks for correcting me.
Yep.
But I think it's really important for us to...
Obviously parents on behalf of the newborn.
Yes.
Worth clarifying.
Of course. But I think it's really important to continue to support new migrants in understanding what actually MyHealth record is, just like, you know, getting your Medicare card. But also, this system is evolving all the time. And I think, you know, MyHealth record wasn't what it is today. And that's because, for example, FECA have advocated for a lot of changes for it to be where we are today. And I think it's important to keep an eye on it and make sure that we, you know, kudos to you guys, well done where you're at today. But, yeah, we'll tell you if we're not like that.
Keep us honest. Thanks, Mohammad.
Thanks, Mohammad. Thanks, Louisa. Thanks, Chris, and thanks, Karen.
Thanks, Mark.
Well, it just shows there's still lots more questions, lots more issues to be discussed with My Health Record, and we will be having a sort of a wrap-up My Health Record estimate session, as we're calling it, next month. I think it's October 4, so watch that space on the Consumers Health Forum website. Thanks for joining us today, and thank you very much to our panel. Thanks and good afternoon.
Thank you.
Thank you.